Good morning, everyone, and welcome to the Telemedicine Echo. My name is Beth Munson, and I am the coordinator for this Echo. I work for Missouri Telehealth Network and Show Me Echo at the University of Missouri in Columbia. I am going to turn this over to our facilitator, and she's going to get us started. Hi, Evelyn. How are you today?
Doing well. Great to see everybody online. I know we were chatting before. This is the warmest birthday I've ever had, and I couldn't think of folks I'd rather spend it. So welcome to our Echo today. I'm from the Heartland Health Resource Center, and we're glad you're joining this Telemedicine Echo. That's a collaboration with our HTRC partners and Missouri Telehealth Network. As we begin today, just a few reminders. The session's being recorded, and we'll share it with you afterwards. Your microphones have been muted, but please do unmute or use the chat to talk. You can test out the chat by typing your name and organization so we know who's here and joining with us. We appreciate you keeping your cameras on if it's at all possible, just so it feels more like a community and that we're getting to know each other. Finally, you'll be sent a survey at the end of each of our Echo sessions together, and we really appreciate you filling those out to help us know how we can continue to tailor these Echoes to best meet needs. That being said, I would like to introduce our hub team today. So first off, I'll ask Robert, could you introduce yourself?
Sure. I'm Robert Stiles with KU School of Medicine, Department of Pediatrics. I work with the Heartland Telehealth Resource Center in areas of policy and others, and excited to be part of this Echo and excited to have everybody here today.
Super, thank you. And Tim?
Good morning. I'm Tim Davis. I work as a telehealth manager at Oklahoma State University in Tulsa, and I work with HTRC for Oklahoma.
Super, welcome, Tim. And let's see, Karen.
Hi, everybody. Karen Edison. I'm the Senior Medical Director for the Missouri Telehealth Network and our Show Me Echo program.
And Christy.
Hi, I'm Christy Ganya, and I'm from the KU School of Medicine. I'm a telehealth communication manager there, and then also work with the Heartland Telehealth Resource Center.
I think I'm seeing the hub. I've seen everyone on screen, but if there's any other hub folks that I've accidentally overlooked, please chime in. Well, with no further ado, I know our guest today, Richelle Marting, has some wonderful information to share with us. We're really fortunate to have Richelle with these and our webinar series. And really, I'll say this at the beginning and end. Richelle loves a tough question, so please do ask your questions today. But if you think of a question later as things come up, we're so fortunate with the Heartland Telehealth Resource Center to have Richelle's expertise. So do feel like you can continue to keep in touch and ask those telehealth questions. Richelle is an attorney who is also a registered health information administrator and certified medical coder. Her practice focuses on medical coding, billing and reimbursement, HIPAA privacy and security, health information management, and regulatory compliance. Again, we're thrilled to hear her presentation today. So please take it away, Richelle.
All right, great, thanks. So as Evelyn was sharing, my background has my bachelor's degree in health information management. Really lends itself to a lot of the things that we've been talking about with the HTRC webinar series in coding and billing for telehealth, but also for today's session and the policies and procedures to back up the services that are being provided, how we document that in the medical record, and how we support the services that are being provided. And telehealth is such an interesting, area because it touches on so many areas of laws and compliance and things that we have to document policies and procedures for. So along those lines, in addition to some of the coding and reimbursement topics and just advice on in those veins, I've spent a lot of time in my career helping with policies and procedures, coming out of as early as coming out of law school, there was a huge HIPAA omnibus rule that came out that required a lot of HIPAA policy and procedure revisions and development. We've had information blocking rules in the last year that affect our privacy and security policies. And of course, everywhere in between, lots of rules that are changing almost on a daily basis, especially in the last 18 months or so. So what I want to talk about today are some of the different sources where we're going to find rules depending on your provider type, different sources of rules that dictate the types and subject matters, and sometimes even specific provisions of policies and procedures that different healthcare facilities and different healthcare providers need to have. So that'll just kind of be an overview of some different places to look. And I know we've got a lot of different, quite a few different provider types. This can be from acute hospital to critical access hospital, FQHC, RHC, CMHC, and everything in between. And that will give you an idea of where to look for some of those rules. And we'll take a look at some examples. So then I'll walk through the different topic areas that telehealth touches. It's not just the coding and billing, and it's not just the privacy and security. We'll kind of take a look at a wide range of subjects that require policies and procedures to be in place. And then I'm going to take a little bit of a deep dive into some of the detailed policy and procedure provisions, not so much the language that you need to have, but the types of things you need to be addressing within these different subject areas. So I'll talk about those, and we'll take a look at some of those specific provisions here later on. So let's take a look first at some of the sources of the rules for policies and procedures that touch on telehealth, depending on your provider type. So I'm going to take as an example a hospital, whether that's an acute IPVS hospital or critical access hospital, and walk through some different places where you would look for rules and requirements. So those hospitals that also have physician clinics, that have medical staffs, that have FQHCs, RHCs associated with them, maybe even ASCs or mental health clinics. These are places where you'd want to look. So I'm going to follow this hyperlink, and you'll have this hyperlink too when the slides get out. And the place that I love to go, sometimes even before statutes and regulations themselves, is called the State Operations Manual for Medicare. If you're a Medicare participating provider or a provider type that gets certified through the Medicare program. So let me pull this link up and I'll show you what this looks like. This to me is sort of the Bible of rules and regulations for different healthcare provider types. And it's in the Medicare Internet Only Manuals. It's the State Operations Manual. Excuse me. And then there is an appendix that has very detailed manuals for every single provider type. So I love to look at hospitals because it's pretty comprehensive in all of the different subjects. But let's go to rural health clinics for a minute. Okay, so we have 90 pages in here that walks through the Medicare conditions of participation for rural health clinics, but it doesn't just walk through the text of regulations. This is a manual for how a rural health clinic would be surveyed by a state agency to be deemed compliant, or by CMS if CMS was to do a survey. So if you were to do a find and look for the word policy, see how that the search bar racks up. We've got 118 references to policies within this manual. So you can do that for every provider type and go through this manual to see what types of policies would a surveyor for a rural health clinic or FQHC or CMHC be looking for that we would need to have in place. Now, that doesn't necessarily mean all of those policies relate directly to telehealth, but many of those policies may need to have some nuances to address telehealth as a mode of delivery, for your patient care, for your medical staff credentialing and things that you have policies for. We want to address those subjects with respect to telehealth within our policies and procedures. So that's one place that I think is, for me, it's a great starting point because it also tells me what the corresponding regulation is. so that I can go back to the regulation and look at the very specific text, but that manual really elaborates on every provision in the regulations and what is to be expected, and really interprets that language where if you spend time reading regulations, sometimes you're like, what does that mean? Or what does that look like in practice? How would we operationalize that? And the operations manual is your key to that. Then your different state agencies, depending on where your facility is located, is going to have different guides and resources for your state surveying agencies and things that they would also be looking for. And the great things about those manuals is that they tend to incorporate not only the Medicare requirements for your facility when your state agency is surveying you to be deemed compliant with Medicare, but also incorporates your state laws and regulations as well. So it's sort of the counterpart to the federal state operations manual, but it goes into the detail of explaining then what you need to do from a state level. And in some instances, those requirements may be different than what we see at the federal level. So we choose the more stringent requirement and we go with that. There are several other bodies of law and resources that I think are great to check out. The HIPAA regulations that talk about privacy and security are obviously a great resource for those of you that are doing telehealth. But let me come back to my state operations manual, and I want to show you, just like the state operations manual for different healthcare providers, the Office for Civil Rights, that really is the federal enforcement agency for HIPAA, has something similar, and it's called the HIPAA Audit Protocol. And if you can look over to the right and see how tiny my scroll bar is, that's because this whole page is just filled with guidance on what an auditor or an investigator from the Office for Civil Rights would be looking for if you had an audit, had a complaint investigation related to privacy or security. So let me do the same thing here. I'm going to do a control find and look for policy, and we get 234 references on this page to policies and procedures. And where this is focused on privacy and security, you can bet a lot of those are going to apply in the telehealth context, right? So that's a great resource to understand if there were privacy security issues, what types of documentation are you expected to have to address the privacy and security in the telehealth care modality. EEOC regulations, so that's equal opportunity. The reason I put that here is particularly, take a drink here. You can tell I'm trying really hard to lose my voice this morning.
Thanks for powering through, Richelle.
It's okay. You know, I was fine when I went to bed. And of course, the morning that you have to give a presentation, your voice goes away.
Please just keep us posted. We can always share some more later on because we want you to be okay.
Oh, I'm fine. We'll power through. The reason I have EEOC recommendation or regulations here that really is more of an employment law body of law is that we're starting to see employment law really intertwined with remote working, which can certainly happen when we've got telehealth, when we have providers who are offsite, if we have nurses who are offsite, nurses who may be paid hourly instead of exempt from overtime, and how we make sure we're capturing their time. And it also intertwines with HIPAA and the privacy and security of remote work and telehealth work. The other thing that made me think of EEOC and Fair Labor Standard Administration regulations is that just in the last, it was November 4th and November 5th, you may have seen in the headlines that Medicare came out with a vaccine mandate for healthcare workers in organizations that are certified by Medicare. So this applied to hospitals, to surgery centers, to long-term care communities, CMHCs, FQHCs, RHCs that are certified by Medicare, not provider offices. So from a billing perspective, place of service 11 were not a part of this rule, but many healthcare facilities were. And this vaccine mandate is really an employment issue, but then it also affects all of these other bodies of law in terms of infection control and policies and procedures. And it affects, in some instances, an accommodation for an individual who may not be able to get vaccinated or has an exemption from vaccination, could be working from home. And so that ties in EEOC and FLSA, because we have to understand the proper procedures for reviewing requests for exemptions without being discriminatory. And if working from home or other settings is an accommodation, how we can do that while complying with wage and hour laws and other bodies of law. So they all tie in very closely to the concept of remote working and telehealth. Then we have state laws that I really think of this last bullet as the state laws and regulations defining the different provider disciplines relationships with patients, meaning when does the provider-patient relationship start? Is it the point of a referral? Is it the point of scheduling an appointment? Is it only once that telehealth service is initiated? Can a provider-patient relationship be initiated by telehealth? Can medications be prescribed via a telehealth visit if there hasn't been an in-person visit with that patient? So those bodies of laws help dictate policies and procedures that are going to apply to our telehealth services as well. So now let's look at some of the different topic areas. I've kind of hinted on that by looking at the different sources of laws. But particularly when I pull up the state operations manuals, for example, those the regulations for different provider types are separated by different subjects, right? So if you're a hospital or a facility type that has a medical staff, there are going to be a lot of rules and regulations on the types of documentation you have for your medical staff, like your medical staff bylaws, your medical staff rules and regulations, policies and procedures for medical record documentation and orders. So we're going to look at some specific areas within your medical staff rules, credentialing and privileging that affect your medical staff specific to the telehealth modality. Patient care, right, are all of the conditions of participation that talk about the quality of patient care, who delivers patient care, their credentials still apply in the telehealth modality, but it may look a little bit different. So within the patient care regulations for your provider type, when you do that control find and you look for the word policies, those policies within the patient care regulations need to take into consideration how you address those requirements with an eye towards the telehealth modality. Workflow. So this would be more of a process, more of your procedure, but thinking about the point of scheduling a patient, getting insurance information, getting new patient paperwork completed, signatures, consents for telehealth, getting them actually into the appointment. Where do you send the link for the telehealth visit? How do you make sure you're sending it to the right person? And how do you help that person join the telehealth session? I had an experience with this just earlier this week, or earlier last week, I should say, with my son having a telehealth visit. And it was really interesting to watch the workflow of how this happened and how we were working on scheduling an appointment. And then in that discussion, when it came up that this was going to be a telehealth appointment, that was a whole separate calendar that they had to look at. And so when they were originally finding an open slot for me, they were looking at the in-person appointment calendar, not the separate telehealth calendar. And then once we got the appointment scheduled, the links and everything came to my phone as a text, which worked fine for me. But then to join the telehealth session, I had to be on my phone, because that's where the link was. It wasn't on my computer where I could pull it up and have the telehealth session on my screen. So there's some workflow things to look at there. We also want to make sure we're sending it to the right phone number, right? And that we're not sending that link to someone else's phone number, and that we have consents to send communications to a phone number. medical records, of course, to do telehealth, we're still delivering a patient care service. And under whether you're a facility, whether you're a professional that has your professional licensing statutes and regulations, conditions of participation, payer policies, if we're going to be billing insurance companies, we have to document those services. And so all of the medical record documentation requirements that we would find in the state operations manuals and its state law are going to apply to the telehealth modality as well. I would suggest, I wouldn't say even more so, but some of the requirements are even more specific in the telehealth modality, because if you've joined some of our session on the physician fee schedule, we saw that consent has to be documented on that visit. Or if we want to do an audio only session, we have to describe in the note why we were doing audio only instead of audio visual for some of those services. So the documentation is almost more specific for telehealth visits than it is for your in-person regular services. Policies and procedures for billing. So we're going to take a look at some of the examples of documentation that you may want to think about with respect to who is billing for the services. When you have your distant site provider and an originating site facility, like a critical access hospital, a rural health clinic, a rural provider's office, will the distant site provider assign their right to billing to the originating site, or will the distant site professionals bill separately? Part of that's going to be maybe discussed contractually with those providers, but we want policies and procedures to address that as well. Privacy and security. So we'll look through some HIPAA policies and procedures from the Office for Civil Rights Audit Protocol that have a particular importance with respect to telehealth services. And then, of course, the employment law topics, which I think the two areas that I think are potentially most important or most relevant right now in the context of employment are how you would review and review and approve or decline requests for exemptions to vaccine mandates, which are on hold right now through the court, but in the event they were to be renewed, or any other exemptions really in the employment context that an accommodation could be working remotely, and particularly if that involves telehealth services. So that involves some privacy and security issues on working remotely, and it also involves fair labor standards, wage and hour issues, particularly with individuals that are not exempt from overtime, on how they're going to capture and report their time, even a quick checking their email on the phone and capturing that time to make sure they're paid for the time that they are allowed or forced to work. And the other, and I kind of mentioned the exemption process, but a policy and a procedure for how you review and approve and what standards you use for religious and medical exemptions to different requirements, and how you would look at possible accommodations like potentially remote work. So let's dive into some of the specific policy and procedure provisions or considerations that you would want to look at, particular to the telehealth modality in some of these areas. So let's start with medical staff. And if you were to go into the state operations manual for medical staff, and some of the policy and procedure requirements that are addressed there, the very first piece of documentation in the medical staff rules and requirements for different healthcare facility settings are the medical staff bylaws and the medical staff rules and regulations, and the credentialing of the individuals who are going to be on your medical staff. So one of the things to think about when you are either the facility, the originating site facility that is going to have distant site professionals helping provide care via telehealth, or if you are the distant site professional who's going to be delivering those services, is that application and the credentialing process on how you get approved to deliver those services. There's not an exception for the telehealth providers just because they're not going to be stepping foot in the facility, because they would still be delivering care to patients of that facility. They have to go through the medical staff appointment and credentialing process. Part of that may be to look at your rules and regulations and think about whether you have a category of medical staff membership that your distant site professionals are going to fit in. It may not make sense for them to be considered active medical staff members, because often with the active medical staff members, there are privileges for admitting patients, for attending medical staff meetings, being on committees, chairing committees, for voting rights of the medical staff, obligations to attend a certain number of meetings. And that may not fit very well for the telehealth, the distant site providers. So we may want to look at it. There actually needs to be a separate category in medical staff membership specific to telehealth providers. And in Kansas and Missouri, Oklahoma probably has this too, and I apologize I didn't look at it before the session, but your KHA, your MHA associations have some great model medical staff bylaws that you could look at that have some examples on how you could categorize medical staff specific to telehealth, so that you're not reinventing the wheel, but take a look at how some of the associations have considered or recommended that could be classified, and the different privileges, rights, and obligations that go along with that telehealth category. Licensing in the state where the patients are located. Now I'm going to put an asterisk on that, because that was particularly important pre-COVID, where our state laws dictate that individuals providing services via telehealth to a patient in the state have to be licensed in the state where the patient's located. We've had some flexibilities during COVID. It first came from Medicare. From a billing perspective only, Medicare said back in as early as somewhere between March or May, I lose track of time, in 2020, where Medicare said they would pay for telehealth services if the distant site professional was not licensed in the state where the patient was located, so long as that distant site professional had a license somewhere. So they were really opening the door to be paid for those telehealth services quickly. However, that did not address, from a state licensing perspective, state laws on the unauthorized practice of medicine. So while you could get paid for it, you may have been, you could potentially have been practicing against state laws by not being licensed in the state where the patient was located. Very quickly, once we had governors declaring a state of emergency in their individual states, we also had a series of executive orders or through the licensing boards that allowed physicians and other healthcare professionals to either go through an emergency or a temporary licensing process to be able to deliver care to patients in the state without having a full active license in the state to deliver care. So the asterisk here is sort of a moving target on being licensed in the state and what the current state's rules are for licensure of each individual discipline. Since Kansas and Missouri, and I know Oklahoma's state emergency declarations are no longer active, we now have to go to the state licensing boards and see whether the agencies have created temporary waivers or flexibilities to provide telehealth in the states. And then that also should be addressed in the credentialing process for the facility, if there is one, granting privileges to individuals delivering telehealth. And if there's a temporary licensures, they're not active for as long as a full active licensure is. So we may have to monitor those 90-day cycles of temporary licensures and keep up to date and current on those licenses more actively and more regularly than we would for full active license status. There are also provisions, particularly within the hospital, rules and regulations and conditions of participation with Medicare, specific to the credentialing of professionals who are going to deliver telehealth. So let's take a Kansas hospital who is affiliated with, I'll use KU since we've got folks from KU on the line, affiliated with KU to deliver specialty services via telehealth to the smaller healthcare facility. So there in the Medicare conditions of participation, you have two options under the credentialing and the privileging processes for that smaller hospital arranging for those telehealth services. You could require those distance site professionals to go through your own application, credentialing, and privileging process. That's perfectly fine, and you would follow your ordinary policies and procedures for doing that. The other thing that you have the option of doing is deferring to the distance site facilities application, credentialing, and privileging process for telehealth. There's a little bit of a due diligence to make sure they're going through all the appropriate steps that would ordinarily be required, but that allows you to say, okay, Dr. Marting, if you have been credentialed and privileged through KU, we will allow that to qualify you to deliver services here at our facility. And you just get a copy of whether that includes admitting privileges, what types of orders, whatever those privileges are, and you sort of adopt those or accept those as your own. So that's an option that you could look at, and that's something you would address either in your medical staff bylaws or rules and regulations or medical staff policies and procedures. There's still a requirement to do an internal review of those telemedicine providers' exercise of those privileges to make sure they're kind of staying within the parameters of what's been approved and the quality of patient care at that. I'm using Kansas as an example. That Kansas hospital is still responsible for the care of the patients within their facility. So that it's still part of the review process internally. At a minimum, that review process includes all adverse events from the distance site professional services. So what process would you have in place, either in collaboration with that distance site facility or distance site provider group, or exclusively internally, to look at the quality of care of your distance site providers and at a minimum, identify any adverse events from those distance site professionals and review those as part of your own medical staff patient care and review processes. So I'm kind of walking through the conditions of participation for hospitals that have different categories of rules and regulations. But again, this applies in different ways for any healthcare facility or provider type that's certified or licensed through the state and through Medicare. What has these different categories of regulations? So from a patient care perspective, the originating site where the patient's located still retains the responsibility to have the overall quality of care to their patients, and making sure we have licensed, credentialed professionals is kind of the first step in that process. The next step in that process is actually delivering the care and what that looks like and how we can do that via telehealth. So for example, can we establish a provider-patient relationship via telehealth? Or do we have to have an established provider-patient relationship before we can initiate telehealth services? So in the Kansas, Missouri, and Oklahoma context, the good news is that typically, for the vast majority of cases, we can establish that relationship via telehealth. There's some caveats. So Missouri, for example, says, yes, you can, unless the standard of care would require an in-person encounter. And there's no further description of that. I would suggest that's probably up to the provider's professional judgment on whether in that particular instance, would it be consistent with the standard of care to initiate the relationship via telehealth, or is there some contributing factor, some particular unique element that should warrant an in-person examination of the patient to establish the provider-patient relationship? And while that is specifically called out in Missouri, I would suggest that probably applies no matter what state you're in that would allow the provider-patient relationship to be initiated via telehealth, that there may be kind of an inherent exception that unless the standard of care dictates otherwise. In Oklahoma, we can establish a provider-patient relationship by telemedicine with a few exceptions. For example, prescribing opiates, synthetic opiates, so particular to some opiate prescriptions, we generally could do that via telehealth in Oklahoma as well. So we can start a patient care relationship that opens the door for emergency room consults with specialists. It opens the door for inpatient consults with different specialists. It opens the door for consults in a lot of other care settings that may not be necessarily inpatient, where that distant site professional can see the patient via telehealth and initiate the provider-patient relationship for the first time via a telehealth modality. And that's kind of a state licensing, that's a state law requirement. Now, because the provider-patient relationship is initiated, that then means the distant site professional has some obligations to the patient once the provider-patient relationship is initiated. Medical record documentation, confidentiality, follow-up care, things like that, to an extent, become a responsibility of the distant site professional. Then, as we're in the process of establishing that provider-patient relationship with telehealth, all 3 states, many of our payers, Medicare conditions of participation and billing requirements dictate that we get the patient's consent to deliver the service via telehealth. Now, that does not have to be a long written out form, signed and notarized by the patient. That can be a relatively simple process. It could be verbal that we document. Oftentimes with telehealth, it's done as part of the electronic registration process. So my example last week with my son's pediatrician, I got a text message with a link. I also got an email with a link so that I could click that link, go through the normal registration process, right? I'm updating my insurance. I'm agreeing to be financially responsible for the service. And then there was kind of a telehealth paragraph that says something along the lines of, as a telehealth session, you understand that there are limitations to a telehealth visit, right? We can't put the stethoscope on your lungs and your heart and lungs and listen the way we could in person, that it may require a follow-up visit in person, that there may be some privacy or security restrictions, but it doesn't have to be a long, detailed consent, but something short, a few sentences, typically a paragraph, can cover the elements of consent that we need for the telehealth service. And generally, I see that just incorporated as part of the patient registration paperwork. It could be verbal, though. So if I were to call into my pediatrician's office, my son's pediatrician's office, say, hey, he's having trouble breathing, and we jump on a quick telehealth visit right at that time, and there's not enough time to go through the normal scheduling and registration process. But this is more of a visit to see if he needs to come in or see if he needs to go to the emergency room. And we've actually used this before with my son. We kind of circumvent that registration process, but right there, the first thing that they say, I can tell they've trained their providers really well. Are you okay if we do this via a telehealth visit? And there may be a bill. And then they're just documenting that in the note, kind of the first sentence, patient consented to a telehealth service. Okay, so there's a lot of different ways you can get that consent. The other thing with respect to patient care and delivering these services in a telehealth modality is to look at the particular discipline of the provider who's doing the telehealth service, and under state licensing rules, under Medicare rules, what types of prescriptions, if any, could be prescribed in a telehealth setting as opposed to an in-person setting. So we see from Oklahoma, for example, there's some restrictions on what could be prescribed via telehealth. Under the Kansas Telemedicine Act, it was 2018 or so when that came about, there were some limitations with respect to maternal fetal medicine and medications that could potentially induce abortions that could not be prescribed via telehealth that were considered in the court. So also licensing rules and restrictions depending on the discipline of the provider that may restrict what we can do generally under that licensure that would extend to telehealth. For those professionals who are non-physician practitioners, APRNs, physician assistants working under a supervising agreement with a physician or a collaborative practice agreement. When you do your annual review of those agreements, you may want to take a look at not only what types of medications the supervising or collaborating physician approves that non-physician practitioner to prescribe, but are there any nuances or further restrictions or caveats when the non-physician practitioner is delivering the service via telehealth, specifically that we may want to address in those collaborative practice or supervising physician agreements. And so while I'm calling this policy and procedures, in a way, it's almost like some contractual considerations too that we may need to look at. Orders, okay, so when we've got the rural hospital, FQHC, RHC, CMHC, we've got medical staff, credentialing and privileging. What does the distant site professionals' ordering capabilities look like? Can they directly enter an order for, say, a follow-up test, for labs, for imaging for that patient? That's going to be part of your medical staff credentialing and privileging. It could be something that we're deferring to the distant site facilities credentialing and privileging. But now with patient care, I'm actually talking about how does that order get created? So are they allowed access into the originating site's medical record system? Do they have a username and an account to create an order? How does that get carried out? How do we make sure that that's communicated to the appropriate individuals at the originating site to carry out? On the other hand, if that distant site professional doesn't have access or rights to actually enter an order where the patient is located and in that medical record system, but instead is entering the order in the distant site professional's medical records, we still have to have a way to communicate that back to where the patient is to carry that out, to make sure the labs get drawn, to make sure the chest x-ray gets carried out and fulfilled. And make sure those orders get completed. Encounter summaries, right? So if the distant site professional is rendering a service and documenting that service, where is that being documented? Whose system is that being documented in? And who's responsible for providing a summary, an encounter summary to the patient? You know, here are your medications. Here's your follow-up plan. Here's who you need to coordinate with afterwards. Go back to the FQHC, go back to the RHC, get your blood drawn, get the chest x-ray run, whatever that follow-up is, or therapy, you know, whatever the plan of care is. And then to me, kind of a workflow or practice considerations, just that coordination back to where the patient's located and making sure that the primary care, the folks locally that are carrying these plans of care out, that the specialists or the distant site professionals have suggested or recommended, and how do we communicate that back and make sure they're able to carry out the plan of care. Contingency plans, we maybe start to rely heavily on the specialists that we that we value their opinion through telehealth and their distant site services. But what happens if our systems are down? What happens if that's in the inpatient setting where we really need that specialist consult? How can we make sure we still have access? And maybe that's through phone only, physician to physician relaying information to try to get the recommendations, in which case your coding and your billing may look different. That may be an interprofessional consult rather than a hospital visit with the patient. But we have to have a contingency plan because we know I'm located in Johnson County, and just last week when we were doing our session for HTRC, my video wasn't working well and I had to take my video off. What's the contingency plan if the technology, especially in areas without great internet connections and bandwidth, aren't cooperating with us to deliver that telehealth session the way we had planned on? So
that's a great example, Richelle. I know you touched a little on this, but Heidi asked in the chat, are the consents usually part of the telehealth systems incorporated into the EHR systems?
Yes, the short answer is yes. If you don't, many of the practices that I'm seeing, and I'll say I tend to see this a lot with those locally providers that we've used just in our family and from my personal experience, are moving towards an electronic registration process, even when the visit's going to be in person. You know, you get a link and you can fill all that information out before you go in, and kind of eliminate some paperwork when you go into the provider's office. So if you already have a system like that, that's electronic patient registration and normal consents for care, right? That's not even specific to telehealth. You can just adapt that a little bit and add some language specific to a telehealth service. I'm even seeing that in some cases, that telehealth consent being incorporated into the registration process, even when the visit that I have scheduled is an in-person visit. It's possible that for some reason that may need to get moved to a telehealth service. And if it does, I've already signed the consent to do that. We saw that a lot in kind of the height of the COVID pandemic, where a provider, when the appointment was scheduled, they're available for an in-person visit, but they may have to be quarantined, or they may have had an exposure that requires them, prohibits them from delivering the visit in person. But I've already signed the consent to do it telehealth, and we just kind of moved the modality to telehealth. That can be done. It could be done in the documentation for the visit itself. So that could be as simple as when the telehealth service is initiated, you have some, I use the example of my son's pediatrician, because I could tell they'd been trained with this language to say at the beginning of every visit, have you signed the consent for telehealth services, or just wanted to make sure you're okay proceeding with the telehealth visit. We may still need to see them in person. Just a short couple of sentences. And then I can see through the portal, when I look at that note, they've actually incorporated that into the documentation of the note, and that's fine too. The consent requirements, kind of state law, and to deliver a telehealth service, they don't have a long laundry list of things that you have to include. So that's not something that we need to overly complicate. We just have to get consent to deliver a telehealth service.
Thank you.
So a few more things to think about in terms of the workflow, not necessarily that these are requirements from Medicare or state law, but I think the process on who's responsible for what in terms of setting up the telehealth visit and all of these, coordination of care things afterwards. These may specify for our providers what applications we can use to deliver telehealth. So, from a privacy and security standpoint, we may not want FaceTime on an iPhone to be the modality or the application that we're using. So our practice will insert the name of the vendor that you have vetted and approved to deliver telehealth. That could be through your medical record system vendor, may have their own telehealth module or application. We all know the big names, the Zoom, the WebEx, those types of applications. But typically, the one or other of the providers, whether it's the originating site or the distance site, has paid a licensing fee to those vendors to use their platform in a HIPAA compliant way. So these are typically not the free Zoom accounts, the free WebEx accounts, insert, any other vendor. Typically that's got to be a paid subscription, so that the communications, all of that transfer of data, the video session itself, any recording of those video sessions are done in a way that has the HIPAA privacy and security requirements in mind. And those are not features that are typically carried out through a free account through those different vendors. Now, if you were to search for HIPAA and telehealth during the public health emergency, you're probably going to see some blogs or some news that the Office for Civil Rights is not going to impose penalties for the use of different telehealth applications during COVID. So I would say a couple of things to that. The Office for Civil Rights did waive you exercised its discretion to waive its enforcement of potential security issues using different types of telehealth platforms during the public health emergency. And that does not mean that OCR waived HIPAA. They simply said if there was a security issue with respect to using different telehealth platforms, they would not impose penalties for that. So HIPAA is still here. All the HIPAA requirements are still here during COVID. Office for Civil Rights is only one enforcement agency. State attorney generals can also enforce HIPAA. And to my knowledge, Kansas, Missouri, and Oklahoma AGs did not also waive their enforcement discretion the way the Office for Civil Rights did. So that wasn't kind of an across the board waiver and protection. The other thing is, now that that could have been an option to switch quickly to telehealth, in the March to May time period last year, but now where we're really looking at telehealth as a long-term solution and program, we don't want to rely on that waiver for the programs that we're developing to continue on, hopefully even after the public health emergency ends, which means in vetting these applications, these systems that we can use for telehealth, we want to make sure we are getting into a subscription or licensing level with these vendors that is what they call them, they're HIPAA compliant platforms, meaning they've got extra systems and securities and protocols in place that are designed to take the HIPAA privacy rule protections into consideration. So scheduling, I came up with this idea just from my personal experience, where we're sitting down, we've got the appointment on the calendar, and then the nurse said, "Oh, wait, you want telehealth? That's a whole different calendar." So are you maintaining two separate calendars, or how are you identifying a visit as a telehealth visit on the provider's calendar, so the provider knows to log in via telehealth and not to go to room 2 for that visit? And how long to schedule for a telehealth appointment, where we typically in person would have a new patient visit, maybe 30 or 45 minutes, where an established patient visit might only block off 15 or 20 minutes from the provider's calendar. So those are kind of some workflow considerations we want to look at. The notice of privacy practices, that's a HIPAA document for new patients, since we can establish the provider-patient relationship via telehealth. That means that distant site professional, who themselves are a separate covered entity, have to have a way to get a HIPAA notice of privacy practices to the patient, and they have to acknowledge their receipt of that document through initials or through a signature. So that may be part of the registration process. From a workflow standpoint, that may be happening at the originating site where the patient's located. And we have a workflow saying, distant site provider, we're accepting the responsibility to communicate that notice of privacy practices. But whatever that originating site's privacy practices are, have to then align and be followed by the distant site professional. So if, let's use KU Physicians Group, if their notice of privacy practices are different or have some nuances from what the rural health clinic in Kansas's look like, then that's something from a workflow perspective we need to take into consideration, and whether the distant site professional themselves needs to take on that responsibility. In setting up the telehealth session, this can be done a lot of ways, and I'll pick on Zoom since we're using Zoom for this session, but Zoom can be set up to have one link per user. So my Zoom account, I may have a personal meeting room, and if I set up this meeting, you all would access it through that link. If I set up a meeting with the patient would access it through that link. That means that at any time, any patient who has that link may be able to follow it and join in a Zoom session. And we may not want that when we're trying to have a patient care visit that's private and confidential. So there are lots of settings in the way we set up those applications then that someone following that link has to sit in the waiting room, writing, or the lobby. Different vendors call it different things. So the provider has to accept someone into the Zoom session, and they couldn't automatically join. Or maybe each individual meeting has a unique meeting ID, so we don't even run into that issue. How do we share those links? We've got to make sure that the phone number we're texting it to or the email address we're sending it to is going to go to the person who's going to join that session, or the parent or guardian for that session, and that they get access to that link. Had that link gone to my husband, for example, if his email address was on file with the pediatrician, I wouldn't have been able to join because they only sent it to one parent for that meeting. Do they want to send it to both, or do we want to send it to only one or the other? That's probably part of the scheduling process, is to confirm where do you want the meeting information to go, this email address, this phone number, etc. So medical records, I'll go through this quickly because I want to leave time for some discussion and for you all to ask questions, but all of the medical records requirements that we have at state law, the contents of the medical records, timeliness of medical record documentation, signature requirements, all of that is still going to apply to the telehealth modality. So don't forget that. Billing. You could join any of our recorded HTRC sessions that we've done in the last year or so and look at some of the coding and billing requirements for different types of telehealth services to keep in mind. One thing I would suggest too, for those of you that would be the originating site where the patient's located that are arranging for telehealth services from distant site professionals, if you all would be billing the originating site fee, right? That $20 some originating site fee. You also have to have some type of documentation that a telehealth service has been provided to support that originating site fee. And we don't want to forget recording somewhere that has happened in your own medical records. Place of service confirmation. We've got some flexibilities right now on where the patient is located for telehealth, but absent a literal act of Congress, when the public health emergency ends, the patient's home may no longer be an eligible originating site. And so for the distant site professionals on the call, when you're delivering the telehealth service, we need to identify where the patient is: physician office, rural health clinic, critical access hospital, because if the patient's at home, that may not qualify for billing and payment after the public health emergency ends, unless we have some changes to telehealth rules. So privacy and security, all of the policies and procedures that you would already have in place for HIPAA continue to apply to telehealth, but at some point we may want to take a look at those as telehealth becomes a more permanent role in the way we're delivering care, and whether our policies and procedures adequately take the telehealth modality into consideration. Will you, as providers, deliver a telehealth service to someone who's sitting in a public library and you can see other folks around that may be able to hear that conversation, that telehealth visit? For our providers, where do we want our providers to be located? A nice secure location. We may not want the provider to be at home where their kids, their family members may be able to hear or interrupt the telehealth session. And that would be me sitting here. Evelyn and Robert, you all have seen the little kids pop up in my session that I've got to push down like a little whack-a-mole. But we want some privacy and confidentiality, right, in where the services are being delivered. Breach notification, just working with the providers from the originating site and the distant site on, hey, if something happens, if the link went to somebody else, if the encounter summary went to the wrong email address, those types of things, how together, who's going to deliver the breach notification? Because the distant site professional rendered the service, they're a covered entity to themselves, but then we're arranging for it as an originating site. Who's going to be responsible for sending those notices out and when? Encryption is a really important, I would put that at the top of the list and the considerations for particularly if there's going to be any recording of the telehealth sessions. Where is that going? Where's that recording going to be stored? How do we incorporate it into the designated record set for the patient? Because it actually becomes part of their medical record, that video session. And then the encryption of it. How do we ensure that the telehealth session is encrypted, both in rest in that stored video and in motion? And then just very briefly from the employment standpoint, I've kind of touched on this, but if we have folks that are working remotely, we want to take into consideration whether they are exempt from overtime or not exempt from overtime. If they're not exempt, something as simple as checking their email or making sure that registration links went out for all of the patients that are on the telehealth schedule for the next day. Though that is compensable time that we need to track and take into account and make sure we're paying our staff for. Overtime pay continues to apply to those who are not exempt, who may be working remotely or delivering telehealth services. And then even though the COVID vaccine mandates are currently on hold, not knowing what's going to happen with those in the coming weeks or months, if we have folks working remotely, even delivering telehealth as an accommodation or a medical or religious accommodation to the vaccine requirements, then we have to take into account all the privacy, consider employment issues in their home environment as essentially their place of work, workplace safety, even in the way that their workstation is designed for those telehealth modalities. So I'll stop there. I'm right at the hour, but certainly if there are questions that we've got from the chat or anything that I can address after the session, please feel free to chime in and ask those as well.
Thanks, Richelle. Just fantastic information. Give everybody a minute here if they are able to chime in. We'll make sure that we send out both the slides and information you've shared today, but I appreciate you mentioning the links to some of the billing and coding that you've helped over time, because that may also complement your presentation today.
Yeah, absolutely. And following those links, truly the state operations manual is one of my go-tos. So click that link for your provider type, search for policies and procedures, and with the references that you see in there, try to think about whether there are any telehealth nuances to those policies. Again, this doesn't have to be a separate long policy for telehealth. It could be a sentence. It could be changing a few words that take into account the telehealth modality.
Well, I think that's really reassuring to hear, because what was running through my mind as you kind of talk through the list is, oh, it's a lot of check marks, but I appreciate what you're saying, that it can complement some of the work and be a few sentences.
Absolutely. Into the things we already have. And just as part of our review process, just be thinking about how any policies and procedures you currently have into effect may need to be kind of tweaked to take the telehealth services into account. And I do see we have one question in the comment. Where's the website for the internet only manual? I can tell you quickly, but it'll also be a link. I can flip back to that slide really quickly here. Sorry for going so quickly through this. It'll be a link here that you can click on when the slides go out. But if you go to cms.gov, and over on the right-hand side, you're going to see a link for manuals. And there's benefits manual, there's reimbursement manual. You want to click on state operations manual. And then there's another link that says appendices. And that's where you're going to see a link for all of the different provider types that you can click on and pull up the survey manual, search for policies and procedures, search for telehealth even. Some of them already address telehealth specific nuances in there to take a look at those rules and requirements. It's a great resource.
Super. Well, again, thank you all for joining today. Happy holidays to everyone. We look forward to seeing you in the new year. And thanks again, Richelle.